Late. I have no idea. I just had it there, so that's it.
I think yeah. No, she's not here. Like, no. Okay.
So doctor might be more, but the doctor, just to make sure the voice, the voice is working. Yeah. Oh, we lost him. We lost him. Can you hear us still? Can you hear me? Can you hear me? Can you hear me? Are you locked in?
No. He wants, let me log into the okay, I can log in. Oh, okay, yeah.
Or you know what? I didn't want to. I don't want to. Because my Lord is my phone.
Hello.
Yeah, I think it's coming.
Are you talking?
Hello. Yeah, you can hear me? Thanks, Megan. A bit of a panic, but it's over now. Good. Right.
No, because it's family. I don't know if the.
Really?
Yeah. Because I know ladies. More than guys.
So it's the shopping.
It's really like it's.
Yes. Good luck, Megan.
Yes,
Good luck.
Chris left me a voicemail saying if there's anything that it costs.
Christmas shopping. Yeah. But you take for me.
No, I need the help.
I need to help you. You got that. There's nothing there.
I think so.
You get.
I went for NI. For the dog, but no, Chris is just at an appointment. But the rest of my that you guys are needing help with that. So we can figure it out.
You got it all.
A lot of them know. Okay, don't talk to Chris, he's not actually there with me.
So we're screen sharing, we're good, and the audio.
Okay, I think I've seen you in passing, but I will tell you face to the name.
So who comes to this?
Carlos from in person.
Hello?
Yeah, Carlos from the Zoom. And so all that is just.
Post Lucy.
Yeah, no problem.
And have you had 2 other sessions already?
Yes.
I had an exam in the morning. What's the? Well, no, that's what I was handling. Or over there. Oh. The work was started on time.
Tell us what we discussed on. Hopefully, I'm thinking, we have a long day. He's the most talking. His kid, he probably could be. Did you want the camera on?
Are the fellows logged on?
We're all here. We're all here in person. We all talk to Martin.
Live and in color.
Excellent. Sorry, I'm on ATB, so I'm not, I mean, I'm live and in color, but through your video screen.
By the way, there's evidence, Chelsea.
Excellent. I was sad when I realized that I was going to be here, but it's the hybrid rounds, we certainly get more folks because it's easier.
And of course,
I'm not sad you're here.
For some reason, I didn't think it was going to be virtual, just in person, but your colleagues got me all linked up in 2 minutes or less.
Yeah, the owl, the fancy mic is actually pretty good. Like it, I mean, some days it works better than others, but I mean, you can hear pretty well. And I think it's, yeah.
You're good for now. Shall we start in the interest of time?
Yeah, and I must apologize. I have to leave at 2 to 3. I have another meeting and babies. But anyway, yes, we might as well. I think we've got, I mean, you guys have got the fellows and yeah, go ahead. We've got some folks online.
Good. You folks in the room can hear me okay?
Yeah.
Sure. Perfect. I'm Bruce Martin with the Pediatric Palliative Care Program, and my colleague Simone. I think most people know each other. Make sure I've got things well doing here. Sorts of images that I don't want or need.
Just before Dr. Martin starts, you're able to see the slides, right?
Chelsea, you can see the slides?
Yeah, we can see the slides.
Perfect, perfect. So I do want to start with an acknowledgement. I recognize you've been amongst us through the day, and perhaps there have been others. But do wish to acknowledge that we are on Indigenous and traditional territorial land. I put particular emphasis on this in part because the first 3 decades of my clinical career, I worked in Northern Canada, principally with Indigenous communities, and was absolutely aware of the history that impacted those communities, those individuals, and their traditional lands. And we acknowledge that there are many mistakes made. We acknowledge there's a need for truth and reconciliation. And we reconcile in collaboration with our ancestral members, whether they be Métis, First Nation, or Inuit, as we move forward in a spirit of reconciliation. Nextly, to acknowledge as well the fact that, as you know, we care for individuals from Nunavut, specifically Pediatric region and Sanikiluaq, Hikitanik region of Nunavut, and again, have experienced myself many circumstances that have impacted those communities. Also, I'm sure you're all aware that we are very much experiencing an overrepresentation of individuals of Indigenous ancestry in the work we collectively do, including in neonatal and perinatal care, and therefore particularly important that we take these issues in consideration. I must admit, in keeping with that acknowledgement, a longstanding friend and colleague, Elder Dr. Margaret Lavallee, has worked with me for years. I asked her a while ago if there was a word in her language, Ojibwa, for palliative care. She said not, had not heard of one. So I said, could you seek counsel from your elders and knowledge keepers and come up with a word? And this is it, Agamano, Gana, Waba, Negabu. And when I said to her, but what does that mean in your language? She said this, it means we will look after you in a good way, which I think is an absolute representation of what palliative care is and should be. So a significant attribution to Margaret. I have no personal disclosures as I start this, but I do want to talk about attribution, the act of giving someone credit for doing something, and I do that specifically in this realm of neonatal care. I was very advantaged in my undergraduate and postgraduate education to have had significant support from neonatologists. They were aware of my desire to work in northern remote areas of Canada, and they were aware of the need for additional neonatal training. But in addition to that, in the late 70s, it was truly in the earliest era of palliative care in Canada. And I must admit that the skill set that was manifest by some of my neonatal mentors and educators was an incredibly good example of the comprehensiveness of palliative care in many different regards. One might say, and they justified their skill set, defend their skill set by saying at that time, let me date myself, we did not have artificial surfactant, we did not have TPN, we did not have jet ventilation. So viability was really in around 30, 31 weeks. So the need to meet with parents and talk about the outcomes of their preterm infants, even in the 30-ish week realm, was well manifest to us in meaningful communication. So lots of attribution to them, as well as attribution to the northern communities in which I worked with the skill set provided to me. Secondly, apologies, again, because I have rarely presented to this group. I think the last time was about 3 years ago. We were talking about the use of gabapentin for neuroirritability. So I must admit, I may not know, I do not know your understanding or skill set regarding the topic of discussion. And I wasn't quite sure who all was in the audience. So I must admit my apologies if I seem a bit anxious, a little bit of imposter syndrome today, because many of you may know more about these topics than I do. Session objectives, I chose not to do that usual thing by saying at the end of this session, you will ... So the session objectives are really to talk about goals of care discussions. And I want to just not briefly, I will touch on theory, then guidance, then practice. And feel free, acknowledging the fact you've been in sessions all day, feel free to interrupt. We will hopefully have time at the end for a bit of discussion. So turning to theory, and again, an apology, I'm often faulted for foundational stuff, but I thought it important that I tell you from my personal approach of the definition of pediatric palliative care. So a bit of a review or a refresher so that we're all on the same page for today's discussion. I am significantly adherent to definitions that are provided by the World Health Organization, by the International Children's Palliative Care Network, and Together for Short Lives, the latter two are both UK organizations. But very simply, palliative care is defined by the World Health Organization. Palliative care for children is the active total care of the child's body, mind, and spirit, and gives support as well to the family. Remember, this is specific to palliative care for all children. They are very explicit that it begins when illness is diagnosed and continues regardless of whether or not a child receives treatment directed at the disease. So it can be starkly different than, for instance, some aspects of adult palliative care. And health providers, all of us, must evaluate and alleviate a child's physical, psychological, and social distress. That includes the family and makes use of the available community resources, and they emphasize that still see you, hear me?
I think
But it
this,
can
the
be-
microphone went off. That's what the problem is.
Sorry,
The microphone went off,
oh,
this thing here.
that went off.
Yeah, I just saw the,
And will now be used, something else is being used. Oh, well, that's all right. Can you still hear me over there? Yep. Okay. And can be successfully implemented even if resources are limited. Now, of course, the discussion today is more focused on neonatal environments, but recognizing that the approaches to palliative care for infants and their families can be provided in areas of limited resources. Home environments. It states very clearly that the aim of palliative care is to achieve quality of life and dignity of death, preferably in a place the child and family is choosing. And as you can see there, I'm going to see if we can get some awful images on the screen there. There we go, that's off. I'm sorry about this, we'll get rid of this too. Sorry about that, I didn't realize it was marring up the image there. And all children with palliative care needs require an individual package of care, including variable components of generic and specialty care in a planned, coordinated, timely, and flexible manner. So emphasizing that in a place the child and family is choosing, and I know that has impact on all of you, because there are times when families would rather be at home, they wish to transition to home, or would rather be, despite our perception of usefulness of intervention, would rather be here. And secondly, an individual package of care, including variable components of generic and specialist care, so they make it really clear that provision of palliative care is not my domain, it is our domain and all individuals involved. And lastly, to reiterate, a planned, coordinated, timely, and lastly, flexible manner. And we'll bring that up on another slide, a very flexible manner, meeting the needs, evolving needs of a child, infant. There are lots of diagrams of what palliative care should be, must be, can be. I particularly like this one. There's some more recent ones. This comes from Ferris et al. Detect your microphone. You've got that image too. Oh, well. I have no idea how to get rid of that. There we go. And as you can see, palliative care is viewed as starting at the time of diagnosis. And proceeds regardless of curative approaches. This is a straight line, whereas all of us know that it actually is a very non-linear and includes bereavement. And if I were drawing this, I would also say bereavement and approaches bereavement start much before the time of death. And also our responsibility collectively in palliative care is not just the individual, meaning your patient, but also its family, caregivers throughout the course of illness and thereafter. So although this is specific to children and a little bit beyond neonate, this particular diagram, the artist remained anonymous, so we don't know who they are, but is a one-door approach, a curative and interactive relationship with palliative approaches to care. Making it even more complex, and one say theory is the categories of pediatric palliative care. And again, you all experience this in the work you do. This is adapted from Together for Short Lives by actually, interestingly, a palliative nephrologist, but 4 groups. 1, life-threatening disease for which cure therapy is available. And that includes, in their example, extremely premature infants. And you all have experienced those circumstances when we think the outcome will not be positive, yet thereafter, and many of you were here the other day after, correct me if I'm wrong, 140 days of inpatient care for those twins. So often things can have a curative approach. The second group is diseases in which premature death is likely. So again, not necessarily in your clinical environment, but over time, the examples they give there, congenital heart disease, for instance. Group 3, chronic progressive illness with the possibility, without the possibility of curative treatment. And again, I'm guessing, although I didn't listen in on the discussion with Dr. Schodeker today, the harsh realities of the high prevalence of progressive illnesses without the possibility of curative treatment, particularly in genetic disorders. And then group 4, irreversible but non-progressive disease, often accompanied by associated complications. And again, maybe not in your practice environment after transfer or discharge, that are likely to lead to premature death. And the examples they give here are individuals with severe multiple disabilities, you know them well, or severe cerebral palsy, where the disease may be non-progressive, but there are complex and frequent associated complications. So turning specifically to neonatal palliative care, and not well described in any one singular document, but the foundations, again, keeping us on the same page as we approach goals of care discussions, the key areas of neonatal palliative care, and the citation here I'm giving is from 2021, recent, but a coalescing of a lot of literature, talk about what are the areas, what are the skill sets essential to neonatal palliative care, and they're listed as here. Being able to lead goal of care discussions, to break bad news to parents and families, discuss changing the code status of a patient. We use the term ACP, but code status. Discussing treatment withholding or treatment withdrawal. Transition to home or hospice is viewed as one of the other key areas. And moving on, foundational ability to address grief and bereavement, to provide antenatal counseling for extreme prematurity, identify life-limiting conditions, provide counseling regarding the prognosis of life-limiting conditions, and more the symptom management and the 10th and 11th of the key areas, assessing for and managing pain at the end of life, as well as managing respiratory symptoms. So those are the key areas that are viewed as the foundational skill set in neonatal intensive care as reflected in the literature. But I would say the tenet, the true tenet of neonatal palliative care is foundations of communication. If one uses, one might say, the definition of tenet being a principle that is an accepted belief of a particular group or groups of individuals. So when you look at the literature in neonatal palliative care, much of it has discussion around quality communication. And again, I apologize if this is redundant to what you know, but the difference between advanced care planning and goals of care. And it's not well recorded in the literature, but looking for a few examples, advanced care planning, this is taken from Nova Scotia Hospice Palliative Care Association. And yes, it's related to all age groups, but very applicable to the work that you do. Advanced care planning is a process of reflection and communication. Is a time for you, this was directed at parents, to reflect on your values and wishes and to let others know what kind of health and personal care you would want in the future for your infant, your child, your family member. Whereas goals of care is again reflected on by the same group. Goals of care conversations occur with your healthcare team. These conversations provide an opportunity to incorporate any advanced care planning you may have done into specific plans for the care of your infant or baby and treatment. It can include medical orders for specific treatments or for the use or non-use of life-sustaining measures. Goals of care conversations can occur at any time during the treatment and care of your infant and may occur more than once if the condition changes and all of you are fully aware of the ebb and flow of status of infants and the need for frequent discussions in this regard. And just a visual image of that, advanced care planning, the reflection on the goals for your infant, the goals of care discussions with your healthcare team, and the decisions that collectively you can make. So turning from the theory of what is sort of hopefully a little bit on common ground regarding palliative care and specifically neonatal tenets of care, turning to guidance. And again, my apologies if this is well known to you, but I thought I would look at what the literature offers. I like browsing through it in an effort to stay current, at least keep up with you. And so what I did with PubMed is I typed in goals of care discussions and neonatology. So in a PubMed search of those two, the first publication in that search in 1989, and up until the current year, 67 results. 5 met my litmus test of assessment as relevant to today's discussion and relevant to discussions of neonatal palliative care. And I picked a few of them that I thought would be of interest to reflect on when we talk about goals of care. This particular one, which again, 2021, you may be familiar with, this came out of America, mostly from the Children's Hospital of Philadelphia. And they do have a significantly active neonatal palliative care program in Pennsylvania, in Philadelphia. So this was goals of care discussions and moral distress among neonatal intensive care unit staff. The discussion, so just summarizing Goodman's work, the discussion, I'll read from it, best practices for goals of care discussions in the NSU have not been well established. And I think most of you would reflect upon that in the same way. This is in part likely related to the difficulty in defining what makes for a high quality goal of care discussion and how to measure quality. Summarizing the discussion, for this reason, they sought to establish: 1, if provider moral distress might be a useful indicator of high quality communication and goals of care discussion. And secondly, if there are specific replicable elements of goals of care discussion that correlated with lower levels of provider moral distress and therefore high quality communication. So it was an intriguing study and interesting. About the same time, they were looking at moral distress before and after a goal of care discussion, and looked at the opinions of neonatal care providers regarding their stress levels in goals of care. They found that moral distress of neonatologists or anyone involved in clinical neonatal care, moral distress of providers was significantly reduced under this kind of long list, but there's a huge list of things where there was either enhancement, meaning distress got a lot worse, or there was no change in distress. But they found that the moral distress of providers was statistically significantly reduced when family or other support individuals were allowed in discussion with the team. Now, some of these may seem foundational, but nonetheless evidence that they're important considerations, where parent preferences were respected regarding who is caring for their child, understanding parents' emotional state, pain and suffering and life balance against long-term outcomes, respected parents' views about their child's quality of life, supported, meaning neonatal care providers supported parents in order for them to come to an agreement. The providers supported parents, whatever their decision, and parents felt that the right decision was made. So these were the list of things where, when these components of a neonatal goal of care discussion were embraced, there was less stress amongst the neonatal providers. And in summary, change in moral distress among providers may be a useful metric of quality of the goal of care discussion. And additionally, there are identifiable elements of discussion that are associated with high quality discussion. And specifically, we must consider focusing on expressing respect and support of parents' views and decisions in goals of care discussion. The next one that I found useful in this discussion, again, not quite sure who my audience was, but gaps in palliative care education among neonatology fellowship trainees. So sorry, folks, if it's getting your fence taken, and there's no intent for you to be looking at the undercarriage of a bus. But nonetheless, interesting article that comes out of America by Dr. Raitt and Associates. What they did is they did a survey of all neonatal fellowship training program directors in the United States and fellowship trainees, anonymized. Introduction to this I found important in today's discussion. Although neonatologists report caring for dying infants frequently, they often have received little or no training in end-of-life care or how to support a family through child loss. Dealing with dying critically ill babies is intense. This is an incredibly important part of the work you do and has a major impact on the dying baby, their families, and the healthcare providers in the NICU. This prompted them in America to conduct their survey to determine the extent to which neonatology fellowship training programs are providing formal palliative care education to their trainees, as well as to assess whether the education is effective in increasing fellows' self-reported comfort with the 11 key skills. And the discussion talking about broad range of skills are necessary. Although competency in pain and symptom management are important, what sets palliative care apart from other fields of medicine is the focus on high-level communication skills. So again, going back to the tenet of the work you do. Bereaved parents report that insensitivity, lack of emotional support, and poor communication from care providers, and in particular from physicians, that's some of us, has a lasting impact on how they experience their grief and on their long-term healing. A very recent publication is C2021, involving a very significant number of American neonatal fellowship programs. They concluded that most fellows who participated in the survey, 80%, reported being uncomfortable or only somewhat comfortable with the 11 key areas of palliative care, the 11 key areas I listed before. Fellows who reported receiving palliative care education were more confident in their abilities in many of these areas, suggesting that formal palliative care can be effective at teaching fellows these vital skills. They advocate that all neonatology fellowship programs should have robust palliative care education curriculums to provide fellows the proper tools to navigate challenging conversations, getting back to the tenet of communication surrounding a dying baby. An interesting nuance in that document, I read through it, that there were a significant number, again, there's no intent for anybody to look at the undercarriage of the bus. Quite a number of program directors said that they had a robust palliative care education program for their fellows, but some of the fellows in the program said that they did not recall receiving palliative education. So it was interesting. And by the way, there were no Canadian centers involved in that study. The next topic I Googled in, just for interest, goals of care conversations, not discussions, but conversations in neonatology. There were only 6 results in the last 8 years. The first one in 2014. 2 were duplicates from the discussions I just mentioned, and 1 was specific to withholding or withdrawing life-sustaining intervention. So I must admit, that topic is not necessarily today's topic, but I thought it was relevant to goals of care discussion. This is the title, Communication with Parents Concerning Withholding, Withdrawing Life-Sustaining Interventions in Neonatology, published 2014, and the authors were in Quebec, Montreal, at the University of Montreal, and where they do have a center not only of neonatal palliative care, but also bioethics. So I found this interesting, and again, recognized as a bit of a one might say, a bit of a stretch to goals of care specifically because it's specific to intervention. But the abstract quoting from it, the nature and content of the conversations between the healthcare team and the parents concerning withholding or withdrawing life-sustaining intervention varies greatly. These depend upon the status of the infant. For some neonates, death may be imminent, while other infants may be relatively stable, yet with a potential risk for surviving with severe disability. Healthcare providers also need to communicate with prospective parents before the birth of premature infants or neonates with uncertain outcomes. So embracing in their study, and again, 2014 specifically, talking about the essence and importance, again, of communication and appropriate conversations. So Dr. Janvier and her colleagues proposed a mnemonic, and perhaps again, my apologies if this is well known within this group. It certainly was, it's just antedated the work I was involved in neonatal care. The mnemonic they proposed to guide fruitful discussions, and that's actually the wording in their abstract. The guidance for fruitful discussions, and I don't know how to pronounce this. I don't know if it's in Quebec, it sounds different than sob pie, but I guess it's sob pie. And just looking for a show of hands, does anybody know sob pie? Oh, okay.
Sounds sad.
Sob,
Yes,
sob pie it
yes,
is.
it sounds yummy.
And
But
so what they did is they validated the work they were doing in terms of goals of care and meaningful discussions about withdrawing or withholding therapy. So there are the letters. S is for what is the situation. O is for opinions and options and the personal biases of healthcare professionals and alternatives for patients. B is basic human interaction, which I'll get back to in a moment. P is parents, recognizing their story, their concerns, their needs, and their goals. I is for information, meeting parental informational needs and providing balanced information. And emotions, relational aspects of decision-making, which include emotions, social supports, coping with uncertainty, adaptation, and resilience. So the SOB-PI mnemonic to guide the discussion on withdrawing or withholding therapy. So a structured approach, which has since been studied and validated in terms of enhancing meaningful communication with families. I wanted to pick up on this, and again, no intent to throw anybody under the bus, but we know we have failings. Under the B of the SOB-PI, basic human interaction, there is little empirical evidence on how to improve communication, my emphasis, with parents regarding withholding and withdrawing life-sustaining intervention in ICU. Most healthcare professionals believe they interact with parents in an empathetic manner, but sometimes that is not obvious to the family. Often, it is not what the doctor says, but how it is said. This was at the same time as some very significant research coming out of similar centers in Quebec about professionalism, documenting the fact that most of us view ourselves as having professional attitudes, behaviors, and a skill set, not always shadowed, one might say, in opinion by those with whom we work or our patients. So they, in the basic human interaction part of the SOB-PI, gave a simple list of suggestions to ensure good basic human interaction. And I must admit, one might say it's a bit of a checklist, which has some advantages, some disadvantages, but talking how to make sure that basic human interaction, meaning good communication, is achieved with the collaborative network of those who are working in provision of care. Then I looked at advanced care planning and neonatology. Again, we're talking about the reflective issues on what an individual chooses or individuals choose for their child. There were 18 results, the first being in 2002. 5 were specific to perinatal palliative care. And I believe that we should have that discussion if anybody's listening for booking. We should have that discussion. There's some really, really good literature on the fact that perinatal palliative care's time has come and should be well-defined, well-coordinated, well-resourced. And of those 18 results, sorry, 5 were specific to perinatal care. 1 is specific to today's discussions, and that's this one. Top 10 tips palliative care clinicians should know about prognostication in children. And this comes from a truly international network, representatives of the UK, America, Australia, and Canada. And they talk, now again, a bit of an extrapolation, but digging into that particular article published in 2021 gives us some good information about approaches to communication. I leaned a little bit on tip 3. When discussing prognosis, clinicians should begin by exploring a family's cultural needs and norms and end with honest, complete, and equitable information delivery. So one would say of the 10 tips, embedded within that paragraph, and almost every word of it, again, is an enhancement, need for to enhance the environment in which we work, particularly with the diverse cultural needs, etc. They suggest furthermore under tip 3 that emerging guidelines suggest clinicians must approach all prognostic communication first with curiosity, assume nothing, and deliberate. So assume nothing, it's again, personal apologies, that when I hear, oh, so-and-so is at X number of weeks with a lethal anomaly, making sure that we do explore that with curiosity and assume nothing. And then next, assume nothing and deliberately explore a family's cultural needs, norms, and style. And again, recognizing this is an international network that published this tip. And again, in many of the nations represented, dealing with significant individual populations that have been impacted on barriers to access to care and acceptance. When families are non-English speaking, communication must be done with a certified medical interpreter. I know you have all experienced that. And next, clinicians should deliver comprehensive prognostic information compassionately and honestly. And recognizing, as it says here, first with curiosity. So making sure we explore not only the aspects of the illness, but the aspects of the family. And that made me turn to this particular document, liminality in pediatric palliative care. And I'm going to look at a quick show of hands. Has anybody used liminality in a sentence in the last 6 weeks, 6 years? I never heard of liminality. However, it's in the literature, quoted by Brian Carter. Some of you may know of him. From Wisconsin, is heavily published in perinatal and pediatric perinatal, neonatal, and pediatric palliative care. A neonatologist, a medical ethicist, writes great stuff. We reference another work we're doing. So liminality. So here we go. Palliative care for infants, children, and adolescents. So this is all embracing, but I thought particularly important in our work today. Palliative care for infants encompasses numerous transitions and thresholds of uncertainty. So although he's talking about all age groups, just think about the threshold of uncertainty in the last week regarding a specific patient in your care. That challenged conventional clinical medicine. The concept of liminality gives validation to the patient or families being stuck in places betwixt and between. So when I looked up liminality, it's hard to find a really good definition, and I don't think it's a valid Scrabble word. But basically, it talks about this whole issue of betwixt and between. And the fact that everything is an ebb and flow and uncertainty. So it provides liminality, a framework for addressing the unbound spaces that patients and families occupy. What is past is behind, the present place is tenuous and temporary, and what is ahead is uncertain. So it's an interesting, I like Carter's writings. It's an interesting brief read, just talking about the profound uncertainty that we as providers deal with, but our patients, our families deal with because of the liminality of their infant. So that was a quick literature review. You could say one had 67, one had 8, one had a few. Interesting in neonatology, when I did a similar search, 51,000 publications in the last 60 years. Advanced care planning in the last 70 years, 13,000, and goals of care, believe it or not, I have a hard time with this, since 1938, 142,000 discussions. But isn't it intriguing, we talk about goals of care and neonatology, there are only 6 or 8. And goals of care discussions, no more than 60 ever written. Meaning we are on the leading edge of a good wave in terms of looking at the need for many things. So then turning to explicit guidance, and this was attribution to the Canadian Pediatric Society, of which I presume many of you are members. They do have an advanced care planning document. It was first posted in 2008. I reviewed it again. It was reaffirmed in 2018 and has not been updated since then. It is readily accessible. Written by a clinician ethicist with lots of consultation and input. Again, this is embracing all age groups, but interpreting it for neonatal. The key points in that practice guideline: advanced care planning requires effective communication to clarify the goals of care and establish agreement on what treatments may or may not be appropriate to achieve these goals, including resuscitative and palliative measures. So again, although it's all embracing all age groups in pediatrics, can be very specifically applied to your work. They talk about problems and statements of problems. I've only cited a few that lead to challenges and opportunities, but the problem, they say the stimulus for discussion is often the anticipation of impending death, where the expected outcomes of discussion include do not resuscitate orders and palliative care consultations. So again, reflecting on your own personal work in this environment, how often it is that we may delay a discussion, but certainly when the need arises, meaning the anticipation of something briskly changing, the stimulus for discussion is there. They do state in this document, and there has been research to support it, that parents may be overly optimistic compared with physicians about the child's prognosis. The converse, however, may also occur. So going back to that sob-pie mnemonic, having a good understanding of the relationship with the parent is an important consideration. The converse of healthcare professionals may underestimate parental understanding and receptiveness to discussions about foregoing life-sustaining interventions. Similarly, I think one would say, recognizing this is a brief statement, position statement, that we often underestimate their understanding. And we may often underestimate their need for or wish to have discussions. I embedded this in that series of slides from the Canadian Pediatric. Yeah, go ahead.
I was just gonna say,
And I won't be able to hear you unless I move.
sure. We are working on an update. So the advanced care, so just last week.
You know what I want?
Yeah, that's right.
I heard.
How did you know?
Not yet published yet.
No, it's not published.
No.
It's only in draft. But just because the advanced care planning statement it's very well written, but it does need to be updated because it's been some time since we relooked at it. So Adam Rappaport is leading our rewrite.
Yeah.
And so he presented his draft because I'm chair of the bioethics committee. And so all the committee members met last week and we started going through the draft. So just because of the nature of CPS, it'll be a while before it actually, it still has to be reviewed by so many people, and it will be for all of pediatrics. But I'm very excited by what we've seen so far in the draft. So it actually incorporates kind of goals of care discussions and like some of the key steps, just trying to make it more accessible.
It is intriguing with attribution to the CPS's work originally in the 2018 was embraced and adapted by the American Pediatric Society, where some of the Canadian authors worked together and they have since published. citing the Canadian work. So it's nice to see that it is. I knew it was in a revamp, but I didn't know it was that recent.
Yeah, and it'll be a while before it actually, because it has to get reviewed by so many people, but it is under, revision. Adam Rappaport, is the palliative care
Yeah.
docket. Sick kids was excellent.
Spectacular.
And yeah, right, so,
Yeah.
He's leading the draft, and then we're hoping when it launches, to hopefully have some knowledge translation pieces along with it, which will be great. Anyway, sorry to interrupt.
I will be intrigued because there are some components looking through this kind of literature, there's some components that absolutely need to be embraced, but we'll wait. Embedded in that, I put this slide in. This comes from Dr. Joanna Wolf out at Boston Children's Hospital. Again, probably the longest writing author in pediatric palliative care, huge contributions nationally and internationally. This particular one in 2017 was looking at barriers and facilitators to goals of care discussion, and intriguing this particular slide, which as you see, which you can't see my cursor, I just grabbed one table, but talked about that when do discussions, notwithstanding usually good recommendations, including the CPS document recommended, that they found that the most appropriate time, so should take place upon presentation or diagnosis. So obviously embracing all of the work you do, but typically doesn't take place upon presentation or diagnosis. During a time of stability, and again, recognizing this is embracing all aspects of pediatric palliative care, during a period of stability is a great time to sit down and chat, but again, doesn't often take place as much as it should. But as you can see here, and probably reflecting on our own clinical practices, usually takes place during an acute illness or when death is clearly imminent, which is, as they say, Dr. Wolf and her colleagues say in this document, is not the time, should not have been the time for the discussion. So they talk about ethical issues and discussion, and I'm certain the updated version will enhance that as well. They talk about opportunities. They talk about an approach that integrates the principles of palliative care can be beneficial when implemented early and throughout the course of the child's illness. And I'm sure you could just simply insert neonate's illness, or for that matter, antenatal care. Most parents, they say, in terms of opportunities, most parents want us to discuss advanced care planning with them and help them make decisions. And one of the concluding remarks in the 2018 version is perhaps we need to develop an ACP checklist, much like the mnemonics, much like the top 10 tips, but to make sure that we have a checklist. So turning from the theory, all those definitions and dry as biscotti, turning a bit to guidance, including that explicit guidance from the Canadian Pediatric Society, looking at practice. I did want to bring up the work of serious illness conversations with huge attribution to Ariadne Labs out of America, out of Brigham and Women's Hospital, as well as Harvard School of Public Health. This is incredibly good work along the spectrum of all serious illnesses. The co-founder of Ariadne Labs and still very much involved is Dr. Atul Gawande. I put two of his books up there just for reference because I know I'm not a book club goer, but I know that his book, Being Mortal, is often in book clubs, so to speak, was a big seller a few years back. But also he was author of the Checklist Manifesto, which perhaps you have seen. I decided to have part of the summary. I have huge admiration for his work. He's an American surgeon in Boston, well-spoken, skilled, etc. I love this particular preamble to the Checklist Manifesto. In the 21st century, we can do extraordinary things. We can predict dangerous storms, not so well sometimes, explore distant planets and save people from life-threatening conditions and injuries. Yet highly trained, experienced, and capable people regularly make avoidable mistakes. In the Checklist Manifesto, Boston surgeon Atul Gawande contends the reason is that knowledge and complexity in many fields have exceeded the capacity of every individual to get everything right. Under pressure, we make simple mistakes and overlook the obvious. Drawing lessons from spectacular successes and failures in recent years, he argues that the solution is a checklist. And the book builds a case for checklists and issues a plea for adopting this backstop to human fallibility. And I must admit, having previously been involved in the anesthesia world, when checklists were brought in for anesthesia, checklists were brought in for surgical procedures, made a huge impact on quality of care, quality improvement. It is true that much of that was taken from the aviation industry. And again, in my previous career, all of my work was by aircraft. I do remember asking one pilot when we had a very significant air incident, how could it be that he didn't drop down the nose wheel of the transport aircraft? Because he does have a checklist, don't you? To which he said, well, sometimes we don't use it. Everybody survived, we all do. So the serious illness conversation guides that have been developed by Ariadne Labs have now been adapted threefold with attribution to Canuck Place Children's Hospice in Vancouver, notwithstanding other work done in serious illness conversation guides. These are for pediatric conversations, now a new document for neonatal conversations, as well as conversations with Indigenous families and their patients. So using the backdrop of reducing error, but also making sure, in keeping with the Canadian Pediatric Society, the concept of checklist to guide us, so that we're having a difficult goal of care or difficult discussion regarding serious illness, we have a framework by which we can have and hold that discussion, making sure that we don't miss the key aspects of a goal of care conversation. And now, as I say, focus specifically in the neonatal realm, so that we know how to set up the interview, we know how to conduct the interview, we know how to explore some of those mnemonic, if not all those mnemonic saw pie features, and also come to an agreement on how to document and how to distribute the outcome from that conversation. So in essence, so here it is. And for those of you who are here, there are copies if you wish, because they're in print. And if when it's picked up, I'll keep for staff. So no reason to scroll through that, but basically they're talking about assessing parents, assessing with parents their understanding of involvement and their involvement. We're talking about concerns of assessing the clinical status to help with prognosis. And again, looking at that document, the top 10 tips on prognostication and how to make sure that we talk about fragility, how we talk about different respiratory systems, the symptom burden, etc. And then we're working with, again, many of you may have heard of the wish-worry framework, the rationale for using that. And they give really good examples of how to move forward with that. And then all sorts of optional questions to explore, including exploring one's self-awareness. And again, that's in the top 10 tips as well. So a good foundation with the Ariadne Labs work on serious illness, but adapted for the neonatal setting. And then talks very specifically. So here's the checklist of Gawande. Don't forget to put the nose wheel down. How to set up the conversation, how to assess understanding, share prognosis, explore key topics, and closing the conversation, following which you document it, circulate the document not only to parents, but also to key collaborative care providers. So that's it. I wanted to cover theory, guidance, and practice, and look at some of the research stuff. Bottom line, happy for questions, although I know it's been longish, comments, reflection, and sharing. In other words, if you've got any comments, that'd be great. If you want to reflect on things, that's fine. Sharing, got lots of the foundational literature documents that I referenced to in this particular document. But I also want to turn to Simone, who's been involved with, and others who, in attribution to others, involved with embracing the serious illness conversation guide specific to pediatrics. There is, one might say, a bit of a process journey that's important. Again, you would have been able to avoid it. There were serious illness conversation guides developed for COVID, when 2.5 years ago, we anticipated there'd be huge challenges based on the experience in Europe in particular. But again, the fact that now we have a nice framework as to how to move forward with serious illness conversations and how to build capacity amongst all of our colleagues to have meaningful conversations. And again, there's already literature looking at the validation of these guides, how to teach, how to train, how to reinforce skill set. So Simone, do you want to talk quickly about the process with Ariadne or with Hannah or Canuck Place?
So Canuck Place sort of started looking at the adult versions and started adapting it for pediatrics in about I think July 2017 is when they sort of started to really adapt this for pediatrics, and then neonatology after that. They provide a 2.5-hour training session that can be done online now because of COVID. They've been doing it online for anyone across the country. And so what you do is you just commit to that 2.5-hour session and then go through this guide, get a bit of other background detail, watch a video, and then are part of the session, which includes role play, which I know we all kind of roll our eyes, but it is actually a really helpful way to get feedback from others on how you use the tool with other people that are learning as well. And so we do that as a part of it and then debrief at the end. And so it is a really helpful tool for new practitioners, for people who've been in practice for a while. It's just a really good way to just say, okay, here's a script that I can follow. Here's something I can fall back on to really make sure that I address the needs of families. And so they actually have gone through quite a bit of testing to like make it family friendly wording and kind of pediatric specific, because it's a bit different than adults when you're usually having a discussion with the parents of the child. And so, yeah, it's been a really interesting learning experience. And then a couple of us on our team are now trained to train the trainers. And so that's also something, if it's of interest to you, I can provide. I don't think the sessions coming up for January have been posted yet, but I can get some links to Chelsea. Perhaps I can send them to you and then you can forward them if it would happen to work out. A lot of them do actually happen on Wednesdays. And they almost always seem to fall when we have MFM rounds. So it's really irritating. But I mean, if we have enough interest, I think as a group, we could also start to do some of these sessions in maybe the beginning of the year and start. And it's not just for physicians, it's for the multidisciplinary team. So if we have people who are interested, we could actually start to book some sessions specifically neonatology specific, if you guys would find that helpful.
I must admit this whole issue, because I was previously involved, as some of you know, in clinical skills education, this whole concept of simulation is so nice. There's been some recent work done in Toronto, but similar to the goals of care, similar to the moral distress study, believe it or not, they took pediatric residents and measured their serum cortisol levels during and after a goal of care discussion to see if there was a correlation between perceived adequacy of training and measurable distress. So intriguing stuff. The other thing I should say again with attribution, because I have huge regard for some of my historical mentors, when I look at this particular guide and checklist, although clearly it was not written down in a framework, I remember Dr. West Boston, who was then head of neonatology, Queen's University, setting things up on how you seat yourself and how you invite in the family. how you ask their opinions, etc. And again, I would say from our predecessors, incredibly quality work. But again, we were in an era of no surfactant, no TPN, no jet ventilation. So one might say there was A, a need for such discussions, but B, less distraction by technology and intervention. And I won't tell you how many antibiotics you use now that weren't even invented then, but bottom line is the quality of discussions were important consideration. And the whole sense and evaluation of one's own beliefs and attitudes and behaviors and how that impacts a goal of care discussion and therefore impacts decisions regarding withholding, withdrawing, or treating under circumstances. So this is a good framework. Take a look at it, see how you incorporate it yourself. And as Simone says, moving forward, we have made an approach to a number of different academic units. I have to determine how this can be brought in to interprofessional education here, because it has been validated in many centers in America and Canada.
And it's,
Other questions?
I would also say from this perspective, this focuses not so much on the details of the day-to-day treatments and minute kind of, tapering or titrating of things. It's a much more larger kind of global perspective of how to look at a patient and can be done sequentially with patients. And I think that's where it might actually be very helpful within the neonatal unit, because especially with longer term patients where, yes, there's changes happening, but sometimes it's hard to know how to approach things. I think this could be really a helpful tool to be implemented and used, and just a structure for that.
I wonder if someone responded in the chat about setting it up. That's just before we leave that topic. I wonder if someone put in something in the chat.
Yes, and the chat is an old chat. Oops, a new chat.
Okay. Yeah.
Oh, Chelsea just had to step away, yeah.
The previous
Yeah,
one
but
was,
I think like the formal training would be something
the
like.
previous one was vague and making sure I wasn't stressed out.
Yes, I have a question.
Even will be supportive of hopefully setting that up for you guys.
About the timing of discussion, so when it's mentioned that the most appropriate time of discussion would be at the time of diagnosis or at the time of our, like, we healthcare providers know that this is the diagnosis. Touching, I don't know why defined, first of all, based on what criteria they define that this is the most appropriate time to run such a discussion. I know that the stress with the family might be just in the minimum, and then it will peak later on, especially when the baby is the acute illness. But for me, if I am the sick patient, discussing such a very detailed, sometimes maybe related to the future and its ambiguity, discussing it at that time, I don't believe that I will give all my thoughts as a parent if I discuss, or as a patient. So I don't know if it's always appropriate to discuss at the time or the beginning, especially if the patient is stable, clinically is doing fine.
I hear you. And it's a question too of what you embrace in that discussion. And some of the literature with some of the personal experiences, perhaps a discussion is just simply introducing yourself in a meaningful way, getting to know the parents in a meaningful way, making sure they know who their providers are. Because the culture of our health environment is well known to us, but foreign to others. So the discussion may have little content regarding prognostication or intervention, but as a foundation for discussion in greater times of need. The other, again, bringing in some very old literature, I won't quote how old it is. One I like looking at was written, it's called Pascal's Theorem and the Hanging of Creighton. It was written in the 70s, first journal club I ever went to, that talks about a prognostication from the clinician's perspective. So the hanging of crape being an old tradition of the 14th and 15th century. In other words, setting the stage for a discussion so that things go awfully, there is some preparedness. If things go well, there is a distinct joy. But it's again through lived experience of finding a model of what should take place in the initial discussions, recognizing profound uncertainty, but recognizing that's a foundation for the next discussion. And if there's some scripted wording in this and other documents about how to get yourself out of a mess before you get into it, so to speak.
Yeah, I would agree with you, Bruce. Like, I hear you too, you know, where you're coming from, but it's so much like having a meeting sometimes is setting the foundation and creating a relationship and opening that door so that the family understands, you know, you're gonna engage again in that setting. And, you know, it's at a time, sometimes you engage with families when they're stable, that to me is probably the optimal time, you know, and that the impetus for a goals of care discussion shouldn't be a DNR. You know,
And that's not the purpose of this either. This is just the purpose of, here's where we're at.
Yes.
What might we expect in the future, especially if it's uncertain, because that uncertainty can be devastation and death, or the uncertainty can be living, right? So with some of your patients, you really don't know
Exactly.
which way things are gonna go for a very long time. Like, and to be able to sit in that uncertainty is really hard as healthcare providers, but we sometimes know what might the things be that are coming up that we might have challenges with. And by preparing families for those, when we're in the situation, they're not surprised then. So, but that can take time, that can take numerous meetings, that can take 6 or 7 meetings of, we're still in this, don't know where things are going. And that's okay, but at least we're saying that. And I think sometimes families also take the time to adjust to what's actually happening in front of them. And if we have those meetings and are open and honest, for them to switch to more of a comfort approach can be a little easier if we've prepared them for the fact that that might be coming.
I must admit the literature, particularly on the top 10 tips was one, but also the overall distress is really lengthy about things that were distressing versus things that were relieving of distress, including. But Rebecca, you've had your hand up for a minute. Go ahead. I hope we can hear you.
Yes, Bruce. Thank you very much. Just a comment. Probably next to Molly, I am one of those who had been involved in this subject for a long, long time. And well, first of all, thank you for the talk. It's great. I heard words like empathy, insensitivity, luminality, etc. And those are all very important words to know. To me, it boils down to basic human interactions, you know, how to deal with people and how to deal with patients. I still find it incredibly difficult to deal with families when their child has a terminal illness or unsure prognosis. And I found through the years how helpful, extremely helpful, the palliative care service has been. And I appreciate that very much. Bruce and Simone, thank you for doing what you do. Thanks.
Thanks, Rebecca. Molly, welcome back.
Hi, you can hear me?
Yeah.
Yep.
Okay. I'm sorry, I missed a significant portion of the discussion, but I wanted to bring something up. I echo what Rebecca has said, actually. It's you guys do an amazing job when it comes to the working with families with the uncertainty, and then when things become more certain, continuing to work with families. But I have a question in that I've been reflecting, the majority of the antenatal patients that I see with you guys are not from the First Nations. And so then I'm wondering, because the First Nations parents of babies in the nursery have been deemed, not by anyone in particular, that they're always more difficult to deal with, to come to terms with how things should proceed. So my question is, in your vast experience, both you and Simone Bruce, do you think we serve the First Nations people well when it comes to approaching palliative care or actually interacting with the families at an early stage? For example, in the antenatal period, I know geography is difficult, but now with telecommunication, I mean, one can do antenatal consults with them from wherever and with whoever they would like to be present. So that's my comment and question.
So I'll do my best, Molly. I would say the answer is no. So are we doing a great job? No. And again, that's a perspective of, you all know how many decades of my engagement with Indigenous communities and the work with them. We are still challenged. We are better than we've been, but I think we're still significantly challenged in terms of our understanding of their context and many other aspects. I won't go on too much. We have much work to be done. We are very fortunate that, for instance, in the revision of the neonatal palliative care guidelines, we have really good representation from Indigenous communities. I have been very fortunate to have senior elders and knowledge keepers guide me. And I must admit that I did my master's thesis on the evolution and implementation of palliative care, not specific to infants and children, in circumpolar communities. And there's much to be learned by consultation, engagement, but also the contextual realities of working within their communities. So yes, we have much more to be done. I would say, however, on the good side, that I did see and have good mentorship from elders, but also from other clinicians who are providing exemplary antenatal and, one might say, perinatal palliative approaches to care. We just need to have greater engagement. But going back to your observation that we don't see many of them antenatally, that is absolutely true. I think profoundly underrepresented. But I would also say in our adult palliative care program, we have made a similar observation, and we need to understand what have been the barriers to access to care. Sorry, that was a long answer. We will get there, but we'll only get there with good communication and good engagement. And I would also say I did a presentation recently on parental involvement in program development. We need to engage parents, bereaved parents, in the work we do.
Thank you, Bruce.
I see Anne's hand is up too. Oh, lots of hands. Followed by Sandra. Anne, go ahead.
Yeah, I wish I can see you, but somehow I couldn't. Perhaps this camera is not working in the room. Thank you very much, Dr. Martin. My question is actually related to the baby that we currently have in the unit. It's because yesterday we discussed about the health providers' moral stress that related to looking after this kid. And the baby is antenatally was recommended to terminate pregnancy, and postnatal the baby just survived, struggling with one episode, second episode, third episode of necrotizing enterocolitis. So you touch base a little bit on the moral stress about the health provider. My question is that how we can bring and when we can bring everybody on the table to, for example, the ethic teams, the spiritual care teams, and of course the palliative teams together. And sometimes I feel that if I bring in palliative care team, should I always ask myself the question, should I bring the ethic team at the same time, or should I separate them? Or how we gonna work together and address those kind of stress?
I'll only touch a bit on what you said, and to say that the literature has similarly reflected that on medical ethics are not engaged, medical ethicists are not engaged as they might be or should be, and there are recommendations which may come up from the pediatric statement to increase the engagement. In other words, we need to reach out to them. They have lots to offer. Notwithstanding the fact that the ethical framework of providing neonatal palliative care should be in all of our skill sets, but there are times when absolutely their engagement with us day to day and case by case could be incredibly valuable to enhancing the quality and integrity of neonatal palliative care. And I say there's good guidance there, including in some of the writings of Brian Carter and others. And it's a matter of looking at human resources, but also how we engage those training in medical ethics in the neonatal parameters. I know in one Canadian, I won't identify, one Canadian center, medical ethicists who are in training at that particular university do rotate with pediatric palliative care. And that's something we need to do. But I would also say the literature would show that it's not only medical ethics that is not as present as could be, but others as well in a collaborative framework to providing care, but to give all of us an enhanced skill set to move forward on quality palliative care. Sorry, that's a long answer, Anne. Sandra?
Yes, thank you. Do you hear me?
Yeah, we can hear you.
Okay, wonderful. Yes, thank you so much for that presentation, both Bruce and Simone. I really do appreciate it. One of the things that I think resonates for me as a nurse in the unit when we see palliative care is that having you as a part of the team in those processes is really important for the patients, because it is one of the consistencies that happen in their weeks or days that they're there. And one thing that I would love to see happen more is that we have a neonatologist for those cases, because I think it gets really hard sometimes. And if it's week to week, there's always new thoughts. So those are just some things that I do. What's I think just so important that you're there, because that is that constant. And so I just want to say thank you for that. And I hope we can work to a model that could lead where there isn't always a different message, if that makes sense.
Thank you for that, Sandra. I see, Molly, I think you're positioned to respond, because if you don't, I will. Yeah, I'll let you answer the issue about continuity first.
Well, I don't know that I want to answer the issue of continuity. Continuity within neonatology is extremely difficult to achieve. It's not unachievable, but the way our system is and other systems are, it is extremely difficult. You certainly do provide continuity, and that's what families want. Can we change in any way? I would like to say yes, but that requires much thought from a multidisciplinary group. But I can totally understand from Sandra's point of view, it is always good to have somebody who comes in again and again, and not somebody constantly changing. For the nursing staff, it's much better. For the family, it's much better.
I'm going to turn to Simone a second just to say that Molly is one of our members on the neonatal working group, that certainly putting within the future neonatal palliative care guidelines consideration for continuity has been an area we have wrestled with. And I must admit, I'm sounding a bit defensive, is also an issue we're wrestling with in the Canadian healthcare system in terms of how to create continuity. So I think that it is truly valued by patients. The basically foundational publications on continuity that were done internationally from the patient's perspective are still the foundational document. One of the authors was Canadian, talking about continuity of person, continuity of care, and continuity of management are all important considerations, including continuity of information sharing. Simone.
I also would say, I think in the last probably 3 to 4 years, we started doing the prenatal consults together. So that neonatology and pediatric palliative care team did them together. And I think that's made a big difference in terms of, from my perspective at least, for at least some really good communication and knowing sort of how to respond. So I'm hoping that's made a difference for you guys in the delivery rooms. And then also just kind of throughout the course, if they happen to come into one of the NICUs. So I don't know, I personally think it's been a win in terms of that. And I know that's been around for a couple of years now, but to me, that working together has been quite spectacular.
Yeah, I would absolutely agree with that too. I definitely think that you can consider that a win.
I must admit, the recent document about from Dr. Brian Carter about perinatal palliative care, Its Time Has Come, picks up on some of the accomplishments we've had locally, but we really need to build on what's going, because it is a good model and profound need in this province, more so than many other jurisdictions we're aware of, just simply because the profound impact of founder populations.
I just had a comment and a request, if that's okay.
Depends. I'm just kidding.
So I'm one of the fellows. I think it is essential to make these difficult conversations a part of our training, just like we're trained for skills, trained to intubate, trained to obtain history and a physical exam. I think it is important. I mean, death, unfortunately, is a big part of neonatology.
Yeah.
And those difficult conversations. Then what makes neonates, in particular, a very special population to be taken care of, there's a lot of uncertainty. Not too long ago, one of our attendings had actually kind of shared an narrative article by parents who had an MRI done to their baby. It was a devastating MRI, but then they had pictures of their baby growing up well, meeting their milestones. So again, we're all learning. We're discovering new things every day. Sometimes, again, I love the graph you showed where conversations should be taking place as opposed to when they actually take place. It's always difficult to be in neonatology because a lot of times you just see parents' faces just wanting reassurance. You can't give them that. You don't know what will happen in the next hour or two. So a lot of times, I think it's an essential skill to have. Sometimes it just happens right and then when the baby starts changing. We don't have that luxury sometimes of waiting and setting things up for success, right? Or having parents to take care. Sorry, I kind of drifted off a bit, but I think if there are workshops we can attend, I think that'll be essential.
Yeah, and I think sometimes it's the sitting in the misery where you try to fill the space where there just needs to be silence because you can't fix it. And we're all wanting to fix it because that's your job. That's what you feel your job is. But sometimes you just have to sit in that misery and be a human being and just say, this sucks, right? Like, this is awful. Let's just sit here and let that process that, right? We try to fill space because we say, oh, maybe this or this, and we can try that. It's, you know what, sometimes silence is just enough.
I think certainly well worded in some of the documentation about the careful wording about honesty and truth as we all move forward on things. Sorry, I was distracted. I've been asked to announce to the group that we fell to Belgium 1-0. That's pretty good. That's good news. It could have been much worse. And we knew that it was uncertain, as is everything we do. The only thing that is certain in our work is uncertainty.
And it's hard. It's hard to sit in those conversations. It impacts us personally. Your day is ruined. So if that happens at the beginning of your day, it's hard, right? It's tough to be in those scenarios. And I think that's where, as teams, so you notice, like if you've ever noticed how our team works, like I know all the 5 physicians I work with. I know some of the neonatologists. So often then you feel there's this degree of comfort when you can tag each other off, because it is hard discussions and you don't know exactly what to say next, but usually it's somebody else on your team who can then read the room, take the thing and say, how about this, right? So it's not, you're not alone. And I think that's also a part of recognizing, like, these are discussions that don't happen without your team to be there to support you. And I think that's how you learn from others, you learn from scenarios. I still say stupid things, you know, you just sort of are like, well, that one didn't go as well as I thought, you know? Other times you're like, well, that was so lovely. I remember one time Bruce and I had a conversation. I wish we could have recorded it because it was like the most beautiful interaction with the family. And it was like, oh my goodness, like I wish we could have recorded that, because it was like,
Oh, that one, yeah.
yeah, like perfection, right? Like, and there happened to be other people sitting in there because they said, can we just join you for this from the respiratory team? And we said, sure. And never would I have expected that it would have been so beautiful, right? Because it was this family who was just like, yeah, this is not what we want, this, like, this is our goal. How do we get there, right? So it was easy because they were willing to say, we're in this reality, we recognize it, this is what we want. And sometimes it's hard for families to get to that point to know what they want. And that takes time. And we sometimes want to push it as a healthcare team, but we just have to let it rest, right? Sometimes you don't have the luxury of time, other times you do, right? So it's just learning those things and counting on your team members as well, to just be a part of that misery sometimes.
That's an incredibly important last part. The building the capacity within all neonatal providers, because you have many skill sets, knowledge, etc., that is of benefit, and it's augmenting the comfort and reducing the moral distress of those aspects we're discussing today. So that I would say, again, personal bias with apologies, going back to my original neonatal education. This skill set manifest by Dr. Barry Smith and Dr. West Boston, bless them both, was huge in terms of communication, but also with their knowledge of prognostication, intervention, withholding, continuing care. So yeah, it's a matter of building a skill set, recognizing there are so many other boxes to tick in a fellowship program and in a clinical practice. But I'm getting real conscious of time because you folks have been sitting and listening for 5 hours. Recognizing very willing to share any of that information and then look forward to direction from your leadership over what the next discussions are, notwithstanding probably the time has truly come to have a really good discussion about the value, the nature, the integrity of perinatal palliative care. And as Simone says, some things we have done well, and a question of how to enhance that program. Because as Molly has said, there's some people we just don't see, and we need to have an understanding of that and how to meet those needs over time. So thank you all for attending. There are many more than I thought. I hope that the transmission of the message by Zoom was fine. And
Yeah. Thank you very much, Dr. Martin.
Thanks, man. Good to see you. And Rebecca's gone, so I can't tell you how I met her.
Molly is gone. Chelsea and Eamon, they all left there on service. Thank you very much, Dr. Martin. I still remember that day that you came to my office and you said something. Thank you so much. You're the best. I can't refuse you for anything.
Maybe you could tell my daughter that.
Oh, take care. Bye.